Internet, the psychoanalytic talk, and today we're going to be talking about primary and secondary schizoids. So, before we start, I need to explain that this was very well developed on a theoretical level by Schizoid Vision. I'll be linking everything in the description. So it's her concepts that I wanted to expand upon, but I wanted to expand upon those concepts in a clinical way, meaning the work with the patients. So she distinguishes two types of schizoid, which are on the same spectrum of schizoidness, but are not quite the same. So we have the primary schizoid and the secondary schizoid. So primary schizoids are people who have had trauma impact them before the awareness, before consciousness. So there's no real recollection of the trauma or traumas, but the person might be able to reconstruct them through intellectual understanding or through personal accounts like family members, friends, and so on and so forth. So what's the fundamental core is that those people, the primary schizoids, are going to have a subjectivity which is very close, if not corresponding to Harry Guntrip's criteria, i.e. they're going to value the internal world a lot, much more than the external world, and they're going to have a self-reliance that's much more developed than other people, that they really try not to ask for help. This is because at their core they've internalized that other people and the external world on the whole is A, unreliable, and B, can be a threat. That doesn't mean it's always a threat, but it might be. So, in order to try and avoid the threateningness of the external world, being engulfed by the external world, or by being hurt in any way by the external world, they withdraw. Often, what I've seen in my work is that those people who have primary schizoid phenomena going on is that there is a whole philosophy linked to it. Like, it's not, how can I say, free. It seems to be something that they've thought about a lot, which is very coherent with the idea that schizoids are fundamentally attracted to intellectual subjects, which they can master and use in the internal world. Here, that philosophy is often a philosophy of fundamentally being able to do everything by yourself, being self-reliant, and also not necessarily letting anyone too close, as someone that's too close may or may not be a threat to their core sense of self because of the trauma that happened before consciousness, which they're not aware of on a conscious level, but on an unconscious level there are effects and there are traces of it, traces that dictate a certain form of behavior. But that unconscious behavior coexists, at least in my understanding, with a conscious, virtually choice, but not quite, of a philosophy, of a way of seeing the world, as sometimes them against the world or them independently from the world. What often comes through with those people is that they have the feeling of seeing other people, like seeing them through a window, not partaking in the group. And that's often something that they understand from a very early age, that they're different, that they don't fit in with others. And of course that can apply to a whole range of subjectivities. But in their case, there is that very core sense that they were born different in a way. When I say born, I don't mean they were born necessarily different biologically, but something happened before they could even be aware of it. And that's the fundamental core of primary schizoids, that their whole personality has developed as an effect of the trauma. That doesn't mean their whole personality is trauma, no. But the effects of the trauma were there, a bit like how a dark hole or a black hole might bend the light. That doesn't mean the light is the black hole. It just means that you can see the effects of it on the light. And that's the same. The trauma has had an impact on the personality. And their personality has had to have been built as a result of the trauma and has had effects of the trauma within it. And at the very fundamental core, I think that that's a very important point. Those people might not understand emotionally where it comes from, but they understand that there is something that's painful, and that pain is something you can work in therapy. Often those people, I'm going to generalize here, but they are very, very, how can I say, good candidates to psychoanalysis, but they're also very afraid. So there will be moments of, as Harry Country talked about, of in and out. Like they're going to come for a couple of months, then they're going to leave for a couple of months and come back. That's because they're afraid of becoming dependent at the very core on their therapist. And I also think that even though things can go much better, both in terms of their relationships, in terms of their insights, in terms of an appeasement on an emotional level, they might not be, how can I say, leaving the schizoidness behind. And I don't even think it's that important, really. The most important part of the therapeutic work is to help them being able to make the rich internal world more accessible to others, and to help them be with others in a way that feels right for them and for others. And that's, I think, the fundamental core objective, or even ideal, work with the primary schizoids. And I'm not saying it's true for everyone, right? I'm really talking about my experience here. So let's move on to the secondary schizoids, which are people who have had trauma also, but trauma at a point where they could remember that it was past their phase of individuation. That individuation has allowed them to become autonomous before the impact of trauma, i.e. they don't have to defend as much as the primary schizoids against dependency. They're more okay with the idea of depending on someone else. It's not as intolerable, but there's going to be effects. Those effects are still going to be there, but they're going to be there in a different way, meaning that fundamentally the personality is not as shaped in the schizoid direction, meaning that even though those people have schizoid defenses or mechanisms, they're not going to be fully corresponding to a schizoid diagnosis, so to speak. They can have other types of diagnoses, mainly but not limited to borderline narcissistic, autistic, intellectually disabled, and so on and so forth. But that fundamental core element is that their subjectivity was shaped before the impact of trauma. So in a way, their schizoidness is reactive to trauma in a much more, how can I say, in a much more conscious way, that they understand where it comes from. They might have doubts, but they might be able to pinpoint where it all started going wrong. Those defenses also are, how can I say, often much more nuanced. I would say that it's not about the philosophy of life that the primary schizoids have, but more about I don't want to be hurt ever again, but I also deeply hope in the relationship. I hope that the primary schizoids, I think, have at their core fundamentally. I really do believe that, but it's much more conflictual for the primary schizoids, because they hope, but they're also kind of unhappy because they feel that hope might make them already too dependent. So it's very conflictual internally about that hope. Secondary schizoids, in my understanding and how I work with them, the hope is much stronger. It's very much there. If we were to use Fernburn's vocabulary, the secondary schizoids have a strong libidinal ego, meaning they want a relationship. They really want, but they're afraid, fundamentally, because so much bad stuff has happened that they might be hurt again. And those defenses can be wonderfully overcome in therapy. What I mean by wonderfully overcome is that there is a fundamental hope which makes that those people are very willing to try at a very core level the therapy, that they're willing to give and to receive the therapy to, in a way, build and overcome those traumatic events. And in my experience, the schizoid mechanisms, when we work on them with secondary schizoids, they are overcome in a more fundamental way, meaning that those people can let go of them perhaps more easily than the primary schizoids that have really built themselves on those defense mechanisms because they had to survive, because they were not yet fully individuated, meaning that their personality was built in order to avoid that. And it's much more difficult when your whole personality is a consequence of trauma. It doesn't mean it's only trauma, but it's a consequence to trauma. Whereas if trauma has happened to you, you can then try and work on the trauma because you know it's not you, and your personality is not built to defend against it. In a way, it's as if the primary schizoids were, to use a metaphor, people that were built for constant emergency, whereas secondary schizoids, they can do emergency, but they're not made for it, not built on those emergencies. That's the metaphor that comes to mind, but it's just to give you a clear distinction. In the way of secondary schizoid, I also feel that it also helps, because if you only have this monolithic schizoid as the DSM has, you lack and you miss all the nuance that Schizoid Vision offers with her distinction of it. Because I feel that both are equally benefit from therapy, but in very different ways. I think that primary schizoids will need longer and perhaps a more receptive therapist and a much more perhaps patient therapist. Not meaning that you're impatient in the secondary schizoid, but that it's going to take time, and it's okay to take the time. It's not, therapy is not about rushing, it's about working correctly. And I think that to work correctly with primary schizoid, you need to take time and to be okay with the in and out relationships, with the fear of being too dependent on the therapist, or the fear of being engulfed by the therapist. And that fear of engulfment has to be worked on with the fact of taking a bit of distance, sometimes as a therapist, of not being too much into disclosure with the primary schizoids, but more and fundamentally respectful of their subjectivity. Well, we have to be respectful of the subjectivity of everyone, right? But for them, you really have to be, I would say, even delicate about it. Whereas the secondary, I feel, because there's that fundamental hope that's still very, very vivid in their minds, they connect in perhaps easier fashion, and they are more willing to give themselves to therapy. And it's okay. And I'm not saying that there is, how can I say, good and bad. Absolutely not. Both are ways of being, and I mean that. But perhaps the trauma is more easily accessible when you're conscious of it. The unconscious elements then being able to be pulled back and analyzed also with the gaze of consciousness in the secondary schizoid. Whereas the primary, because it's unconscious, necessitates much more work to be able to uncover and work with. So at the very core, I find that the distinction, did a little French there, is so fundamental because it allows us such a good understanding of the schizoid phenomena in of itself. And I also want to stretch this, that I think that primary and secondary can both be overt and covert schizoids. There's not a question of either or. It's more a question of how does the subjective individuality is built. And I found that subjectivity and that distinction that she makes, Schizoid Vision, is invaluable and so rich and so important for clinical work, and that's what I wanted to share today. And I wanted to share how it can be important in a clinical setting. So I hope you enjoyed the video, and if you have any comments, anything you want to ask, anything you wish to talk about, please feel free to leave it in the comments. I'll see you in the next one. Bye.